He's checking.
Perfect. We'll go ahead and get started. It is my pleasure to be able to announce our Grand Round speaker today. I'm Christy Samadar. I'm a general pediatrician and the residency program director. And so I know how important it is to do vision screenings. As someone who's been practicing for over 20 years, there's countless times that we have discovered there's problem only through the vision. Today, Dr. James O'Neill will be presenting a presentation called a Statewide School Vision Program from Screening to Sight, a model from Arizona. Dr. O'Neill is a board certified ophthalmologist. He's really a pioneer in the field of ophthalmology, and I don't use that word to mean he's been practicing a long time, although he did say that to me. There is really numerous things that are just truly amazing that I read when preparing to speak for him. When you talk of the number of surgeries he's done, it's over 10,000 surgeries. The number of vision screenings that he's helped implement is over 2 million. He has been the first person to use telemedicine for retinopathy of prematurity, the second person to use telemedicine for retinopathy of prematurity screening. And he also co-founded an organization called Vision Quest 2020, which facilitated vision screening, as I mentioned, for over 2 million school children using a computerized vision screening software that he designed. He is also an active volunteer in our community, serving at the National AAPOS Vision Screening Community and Eyes on Learning Medical Advisory Screening. So it is with great pleasure and no further ado that I introduce Dr. James O'Neill.
So good morning, everybody. I am Jim O'Neill. I've been in practice in the Valley for 30 years as a pediatric ophthalmologist. The last 10 years have been here at Phoenix Children's. And I appreciate you taking the time to let me share with you a project I've worked on for the majority of my career, which is developing a statewide vision school screening program for Arizona. This model connects schools to parents, to doctors, to the State Department of Health using a unified vision screening platform, which allows us to manage vision screenings, communicate results to parents, and has a data infrastructure at both the individual and the programmatic level. The potential impact of this program is considerable. There's 2,700 or more K-12 schools in Arizona with over 1.2 million students enrolled. It's broken down by public schools, charter schools, private schools, home schools. And this program is being offered for free through charitable support to all schools in Arizona at no cost to schools, parents, or taxpayers. And I'm thrilled that we've raised $5 million in a little bit over 6 months towards a $10 million charitable endowment, which will make this program permanent so that any school that embraces the program won't have it taken away in the future. We don't have to worry about legislators changing minds or other things like that happening. So I started this program years before I joined Phoenix Children's, so it's currently not under the umbrella of Phoenix Children's, although I've been having active discussions with the administrators about strategic relationships and ways we can work together, and they've been very supportive of me continuing to work on this project on my time away from the office. So why am I here today taking up your time? There's several reasons. Number one, if you're a pediatrician or in primary care, you're going to see children that have been screened by this program and you're going to see reports. Number two is, same thing, if you have children that attend school in Arizona or grandkids that attend school in Arizona, you're going to likely encounter reports from this program. The third is that although this statewide infrastructure really is designed at this point for vision and hearing, because vision and hearing are mandated by the state for schools to perform, they're required to perform vision and screening hearings, it can be expanded easily to other types of healthcare screenings, either in the schools or in homes for families. And that's why I want to make sure that the Phoenix Children's community is aware of it so I can glean expertise from all the different subspecialists to hear about ways we can use the program to make it even better. And so there's an opportunity for Phoenix Children's innovators to participate. For those of you that can't read this, It's two mice speaking to each other and saying, I can build a better mousetrap, but the implications. So how did this all get started? Basically, I was a young doctor in my office, and I was seeing children come in every day that had vision problems that had gotten missed by the system. They were either behind in school, or they had problems that would have been much easier to treat and more effectively treated if we had detected them earlier. So it was obvious to me that there was a need to make the system better. Organized school vision screenings first started in Connecticut in 1899. And honestly, over the course of 100 years, or now 125 years, things have changed remarkably little. Kids line up and they read an eye chart on the wall. It's subject to peeking. It's subject to memorization as they listen to the child in front of them answering the chart. It's subject to inconsistent administration, especially when parent volunteers or people that don't have eye expertise are administering the screenings. You have to subjectively interpret the results and determine who passes and who fails, or who needs to be referred, we say, to make the child not feel bad for failing. And then typically things are still being recorded manually. They may be inputted into an EMR at the school, but those EMR results are siloed to the school. They're not available for parents or for healthcare providers to see. And there's also manual reporting. So trying to communicate with the parents is typically, a note in the backpack, and you hope that it makes it back to the parents and that they know what to do with it when they see it. So I had an idea to just automate the whole process on a computer, which allowed us to use validated protocols and computer algorithms to standardize the testing, standardize the result interpretation, and standardize the reporting. We could eliminate the risk of memorization by doing randomization of the presentations on the computer. We could do automated data management in real time. Since the testing is being performed on the computer, it's collecting the results as you go. And we could even gamify testing. So it's a lot of us have good ideas, but it's hard to do the follow through. And I was at a Halloween party in 1999, and I met a software engineer who had just sold a company and had free time in his hand. And I started talking to him about this, and he was enthusiastic to proceed. There may or may not have been some margaritas involved in that conversation, but he's still working with me 25 years later, so there was something to it. And this was our original dinosaur invention. And it's a matching game where the child sits at 10 feet away and uses, at that point, a mouse extender, or now a wireless mouse, and performs a matching game based on a validated algorithm. Once we developed it, of course, we had to do something with it. So we did get it independently validated against the gold standard. We did a patent, of course. And we founded, probably based on being young and naive and not knowing better, our own nonprofit, which is a big undertaking. We were quite ambitious because we decided our charitable mission was to develop technology infrastructure for the nation's first data-driven school vision screening model. In order to support the nonprofit, my other conflict of interest disclosure is that I am a co-owner of Cloudscaper, which is a software company, and they provide technology services to Vision Quest 2020, which is the nonprofit. In addition, Cloudscaper has cut its teeth on some additional technical expertise by developing the first national database for Lions Club's KidSite USA. We still have a big program in Oregon screening hundreds of schools that's customized for Lions Clubs. We developed a license agreement with Go Check Kids and have a software relationship with them where they took a variation of our vision screening system and put it on iPhones. And it's being used by 3,500 or 4,000 pediatric practices throughout the United States. And then we even dabbled in some international screenings through a relationship with Good Light, which is a vision retail company. And had programs going on mostly in Saudi Arabia and Brazil, but we're in several other countries with pilot programs. So we started this all the way back in the early 2000s. And there, as you know, there's been a lot of technology advancements. Back when we started, it was AOL dial-up. Apple was still something that grew on a tree, not something you carried around in your pocket. There was no cloud computing. There was no AI. But over the years, new systems started getting developed. And so we integrated them into our program so that we wouldn't be a one-horse show. So there's some automated screeners that can take pictures of children and determine whether they're farsighted, nearsighted, or need glasses, such as the Spot and the Go Check Kids screener here, which are integrated into our system. And then hearing devices, because vision and hearing are often performed simultaneously in the school setting, we integrated the most commonly used hearing devices so that there was no manual data input, because I know as doctors how much we like typing things into computers. This was my son early on in the program, who's now 30 years old. But over the years, we accomplished between 3 and 4 million computerized vision screenings at approximately 1,000 schools, and it was all funded by charitable grants. And we had school screenings, pockets of screenings going in probably about 45 of the 50 states, but we had no statewide programs going on until 2019. That's when Arizona became the last state to pass a vision screening law. So they were late to the game. Connecticut had started 110 years or 120 years earlier and passed their mandate. But because of the vision screening law, schools are now required to do vision screenings, and it kind of changed the landscape. That is until COVID-19, in which everything stopped. So all our 1,000 schools that have been using our program stopped using the program because there were no kids to screen. The Arizona Department of Health Services took that screening break to develop guidelines to implement the law. So the legislator passes the law, and then ADHS has to design the details about how to implement it. So in the law that they passed, schools are required to screen children upon school entry, either preschool or kindergarten. They're required to screen again at age in 3rd grade and again in 7th grade. And the systems they use to screen are different. They're age dependent, partly because of we're looking for different things at different ages, and different tools are used in different age groups. So there were a lot of challenges to the new vision screening law, but they can be summarized in 4 main problems. Number 1 is human factor. Subjective screenings by non-eye care professionals. And I would have parents come into my office and say they volunteered to do vision screenings and that they had not a clue what they were doing. And so it kind of fell into 2 camps. Either they referred everybody because they were afraid of missing something, which of course defeats the purpose of doing a screening in the first place, or they helped the kids pass because they felt sorry for them. Core problem number 2 is parents are not present at the time of screening. So a lot of times screenings are happening and parents are completely unaware. And so what we have is a failure to communicate. The old school system of a note in the child's backpack or trying to make a phone call and playing phone tag, it's really not an efficient way, and schools don't have the resources to follow up. And so nationally, probably 25% or fewer of kids who are identified with a potential problem at a school vision screen actually make it to an eye doctor. It's a very low number. And then problem number 3 is data management. Schools need to know who's received a screening, who should be wearing glasses, which is very important because if the kid has glasses at home, but they put them in their backpack and aren't wearing them at school, it affects their school performance. Who's been identified but still needs treatment, who's been treated successfully, and who needs school accommodations for vision problems. And problem number 4 is, and by the way, Arizona had absolutely no data system for all that. Problem number 4 is typically the government, they passed a mandate, but they didn't assign any money for it. So schools were told now they had to do extra work, but they weren't given any funds. They did give funds to the Arizona chapter of AAP to do training so that they could train people how to do the vision screenings, but the schools themselves got no money. And the problem is that an eye chart or a device screening law doesn't really solve a public health problem. It's just one part of the whole process that we need to achieve in order to get the end result, which is finding the kids with problems and getting them treated. There's a series of steps that need to be achieved to get to navigate the child from screening to treatment and get the results back to the schools, but also from a public health standpoint, we need to know the effectiveness of the programs if we're investing in the programs and we're making schools go through these gyrations. And without data, you have no idea if you're really doing anything positive or not. It's all guesswork. So of course, these requirements all kind of fell on the school nurses with no money, no staff, and no support infrastructure, which, you know, they're already overburdened. Some schools don't have nurses at all. Many schools share a nurse between 3 and 4 schools. So it's a real issue to just say you have to do something, but not really give them the tools or the resources to do it. So enter Eyes on Learning. This is a really special organization, and I'm just so fortunate that they decided to land in Arizona through the Piper Foundation. It's a coalition of stakeholders, state, local, and national organizations, all with an interest in children's vision. And this organization was instrumental in lobbying for the passage of a vision screening law to improve state eye care systems. Eyes on Learning is specifically concerned about the tie-in between vision and reading. About 1 in 4 children have some sort of vision disorder, but about 60%, 59% of children in 3rd grade are not reading proficient. So if only a small number of those children who aren't reading proficient could be benefited from just wearing glasses at school, that's low-hanging fruit. And that's the most cost-effective way to at least get a portion of the children who are underperforming up to speed. So as a multi-stakeholder organization with lots of partners, there was a lot of due diligence on the part of Eyes on Learning as to what they needed to do to make the state law successful. And it kind of goes back to the 4 factors I was talking about, but specifically they honed in on data management at the individual and programmatic levels, which was sorely lacking in Arizona. So they went to ASU, they looked at the state immunization database, they went to Google, they went to Microsoft, they looked at different options. Nobody really had an out-of-the-box screening solution. And the problem is, like, the immunization database is antiquated and it's very hard to modify it. It's not being supported actively. And so we, as stakeholders for Eyes on Learning, we explained to them that, you know, we've looked at what steps need to be done, and our system in 2019 already satisfied the majority of the necessary items. But what we needed to do is develop a way to navigate the child from screening to the eye doctor and get those results back to the school. So Eyes on Learning looked at this as a technology opportunity during the COVID shutdown to use technology systems, develop new systems to reduce compliance burden on schools, reduce training for skilled personnel, improve quality, improve parent communication, improve follow-up with eye professionals, use data to improve systems over time, and overall reduce costs. So they underwrote us to expand our program to solve these issues, our nonprofit. And this is what we came up with. Our system is called the iSpy, same as what we started off in 2003. And it's broken into different components. The first component is the vision screener at 10 feet, which is self-administered by a child with a wireless mouse doing a matching game. The state law also required near vision testing. And so since a child was sitting at 10 feet, rather than move the device to the child, we expanded the platform to include mobile applications so that you could do near vision testing, including stereopsis and color vision on a smartphone. And the value of using smartphones is that it doubles as a home vision tester. So we did a validation study here at Phoenix Children showing that parents could pick up the phone application with no formal training and successfully get vision screening results similar to what we were getting in the eye doctor office, using it for the first time. iSpy Connect, we had previously integrated some other screening devices, including vision screening devices and hearing, but we now went completely web-based. So we ended up having to figure out ways to do that differently than what we had done before. And so one way is to integrate it in wirelessly. Another way is kind of interesting. We can integrate any device with a display screen by simply taking a secure photo with the linked phone. It uses OCR technology, optical character recognition, to read the results, and then it gets inputted into the system with no manual data inputting. So none of this requires manual data inputting, unless schools choose to use a traditional screening and manual input. They can do that as an option. We also have a protocol manager, and this is centralized, so you can control the screening from either the school district level, the school level, or even the state level. So you can set what screening systems need to be done at what ages, and it makes it much simpler than trying to refer back to the state law saying what devices to use and what tests to do at certain ages. It just all can be defaulted in there. And it also allows us to monitor how schools are actually performing the screening, what tools they're using, and how they're doing it. And it does integrate into schools' EMRs, although we're not in all EMRs, we're in some. We also have a dashboard so that whoever's organizing the screenings can, at a glance, do searches to see who's been screened, who's passed, who's failed. When parents get the report, if they click on a link to open up their child's report, it will update the dashboard. When they go to the eye doctor, if the eye doctor uploads a report, it will get flagged in the dashboard. So it's a much more useful way to track the screenings. It's much more time efficient than making phone calls and trying to follow up manually. And then we have a parent portal, and the parent portal, they receive a secure email or a secure text, and they're able to see immediately the same day as the child's screening was performed, what the results were. And we also use the parent portal as a parent education and navigation tool. We call it Vision GPS. So the biggest problem is getting the child from the screening to the eye doctor. And this can answer parents' questions interactively. We will advance it over time to help supply school vouchers for eye exams and to tie kids into the eye doctors in their area that are the schools want to use. It's an exciting new area that is working, but still in its infancy. And then I Spy Professional is when the parent goes to the eye doctor, they have a couple options. They can still do a paper report if they want, but it's always been a problem getting those paper reports back to the school. So you can simply take a picture of the eye doctor's report, and it will upload automatically and flag the school nurse portal that the report is there. Those reports right now are not searchable for like diagnosis and that type of thing, but we are working on, again, using OCR recognition and AI to be able to search those PDF files for diagnoses so we'll have a clear understanding of what kind of eye disorders are out there. And then the other option is the same kind of as a paper option where you fill in a list of questions, but these are on the smartphone that the parent has. So the parent opens up her child's report and they can answer a series of questions. And it may just be one or two questions if the exam is normal, or it may unfold based on the previous answers so that we can get more clear detail about what the situation is for that child and what services they need. Should they be wearing glasses and that type of thing? And then finally, we have real-time reporting to the Arizona Department of Health Services, which, of course, ADHS loves. They used to just get Excel files emailed to them, and it was put in a big cardboard box, and they weren't organized, and they couldn't really see on a global aspect what screenings were being performed in schools. Now it's all being done in real time. You can literally just sit on the website and watch the screenings occur in real time, so they know what schools are performing screenings and who's passing and who's failing and that type of thing. Not to the detail level of the individual, but they get aggregate data. So what our system does is it basically connects all the various stakeholders involved in the vision screening process, from school to parents to doctors to the Department of Health. So because of COVID, the law did not get implemented until July of 2024, which the school year is usually from July till May. So during that 2020 to 2024 period, we were building out the system. And the first time that the law was required to be used by schools was August 2024. And we were going to do 50 schools just to test out the new system, but we had a great demand and we expanded to 100 schools and 30,000 students in our very first year. This last year, we expanded to 180 schools and 50,000 students. And this coming year, we expect 250 schools and 75,000 students. And what's really facilitating the rapid expansion is that it's a requirement that schools provide hearing and vision screening results to the state. And if they use our system, they're already compliant. They have to do no extra work. The endowment creates future sustainability because technology is not static. So the endowment will allow us to support this program in an ongoing manner and update systems. We'll do systems improvements, especially concerning AI learning advantages. We'll be able to expand the platform for new devices or screening systems. We'll eventually be able to integrate into fire systems for the healthcare interoperability, if there's a need to integrate into other state databases. And it also allows us to accommodate evolving regulations. So we think we have a better mousetrap today, but we feel like we're going to have an even better mousetrap in the future. So beyond vision, because this system creates a dialogue between schools, parents, and doctors, it could be used for other types of screenings at school. It could also be used for different types of screenings at home. The smartphones have LiDAR, which is the same technology that cars use, automated cars use to drive without a driver. You can use that potentially for autism screenings and for a lot of other screenings if you develop a relationship with the families. And it is a platform for childhood health education and guidance. I think I had a slide that missed. So Arizona was the last state to legislate, but because they were so late to the game, they were able to utilize through Eyes on Learning and Vision Quest technology and be the first state in the union to innovate. So this program has national significance, and it's starting to get fun because we're getting a lot of inquiries from other states, and we even have RFPs from other states to provide a similar type of program to them. So technology is changing healthcare delivery. There's going to be more healthcare delivered at home or schools, but outside of the hospital setting or doctor's offices in the future. And schools and families need a trusted healthcare source in the age of internet misinformation. And we're anxious to develop relationships with Phoenix Children's because they're the logical partner for a statewide public health model to create a lasting legacy of change. So even the best of ideas like a wheel are useless unless you have supporting infrastructure. So if there's a lot of very smart, creative people out in the audience, if you guys have an idea and you could see a tie-in where this infrastructure could help get your idea out there, we're interested in talking to you, but of course, with administrative approval. So that is it. Thank you very much for your time, and I'm advanced to where you need me to be. All right, we're good. Does anybody have questions? Yes.
Good question. Well, we're pulling up the chat. So does the I Spy communicate with the primary care doctor? Just
everything is done. Everything is done via the parent. So the parent is the interface. So in terms of HIPAA and FERPA compliance, the parents, by having it go through them, they're giving implicit permission to share the data. We could open it up to pediatricians' offices, but there would have to be a reason why they would want to use it. And, people have busy offices. So unless there was some sort of an economic incentive or a reason for them to enroll, I'm not sure how much it would get used, but we're open to that idea.
So just as kind of a follow-up, if the parent then comes to the pediatrician and says, my child failed this vision screen, would you recommend that we repeat the vision screen in our office or just help them get to an optometrist or ophthalmologist?
I think you could do either or. It would be interesting to do a study and see which would be better and which we could easily design and do. To have you repeat it and see how often the repeat screens, resulted in a better outcome versus a worse outcome.
Questions from the audience? Okay, I got one more. Another reason that people don't wear their glasses, I've found, is that they've broken them. And then I don't know all the logistics of insurance, but they may feel like they can't get new glasses for a year or a certain time period. Do you know if there are workarounds for this, or if insurances do pay for more than one eyeglasses per year?
Well, yeah, the most important information for pediatricians out there is that just a few years ago, the state passed a law. More than 50% of children in Arizona are on Medicaid. And Medicaid is required to replace broken or lost glasses as many times as the child needs them. So one of the benefits of school is knowing that the child should be wearing glasses, is that they can facilitate that replacement process by interacting with the parents and saying, he didn't bring his glasses or the glasses are broken. And so that, I think, is really a big win for Arizona in terms of the free replacement. But I think there's always been a disconnect between what's going on at home and what's going on at the school. And I'm hoping that we can kind of lessen that disconnect through this so that kids are actually getting their glasses worn.
And there's one comment that I'd like to share with you. Congratulations. I saw this test model at Papa's school years ago. Things have come a long ways.
Yeah. That was our first trial run, is at Pappas, which was a school for homeless kids that no longer exists. Thank you, everybody, for your time. I guess that's it.
Yes.